Sorry for the delay. I have a large slide deck, which we'll figure out how to get over. I could take some more slides out and then make it smaller. All right, I'll start talking. Okay, thank you. And I noticed a lot of you wearing masks. If you have, I don't know if you read Journal of Clinical Oncology, but the Emory group just showed that patients with myeloma getting active therapy don't make great neutralizing antibodies to COVID-19, despite appropriate vaccinations. So it's very important that we still think about this, especially in patients who are still receiving therapy, because it's still a possibility. You may not end up in the ICU, but you may end up still getting COVID and getting sick from it. My wife has chronic lymphocytic leukemia, so we're always thinking about this. So the other thing, while we're at it, is there's a drug called Evusheld. I don't know if anybody heard of that? Good. I'm glad to hear. Evusheld is a combination of two monoclonal antibodies, one against something that's more common in COVID-19, the other has a different, finds a different antigen, as you heard about from Dr. Gertz. And so it helps protect you. So it's not a vaccine, but it's the antibodies, it's the end product of a vaccine. We good? Who knows? All right, I'll just keep talking. And so the antibodies have been engineered so that they last in your body for 6 months, as opposed to a normal immunoglobulin, which lasts for about a month. So the nice thing about Evusheld is that it allows you to have a good degree of protection. It's for any patient who has multiple myeloma, they're eligible for it. So I strongly recommend it as something, in addition to vaccinations, you just have to figure out, there we go. You just have to figure out the appropriate timing, because theoretically it might block the vaccinations effort. So I'll start with high-dose melphalan. I'm going to go through a little of everything because melphalan is not the final word. And as you heard from Dr. Gertz, melphalan was first used to gas people during World War I. And if you want to read a really interesting book by Jenna Conant, and she is the daughter of the former president of Harvard University, and she wrote a book about the bombing of Bari Harbor, where mustard gas was released, and it was all covered up by Winston Churchill. It was one of those things. The Germans had mustard gas, the Allies did, and it was kind of like, we won't use it unless the bad guys on the other side do. And so a Liberty ship full of mustard gas was hit and blown up during World War II and released a lot of mustard gas, and again, led to the whole idea, later pioneered by Goodman and Gilman, that nitrogen mustard can treat certain hematologic malignancies, and we still use alkylators to this day, although we'd like to get away from them. This is my disclosures. There's a variety of companies who have done consultancy and honorarius. I thought it's important I let you know that. And I'll be discussing non-EMA, European Medicines Agency, and non-FDA approved indications. So I like this. This is a little vignette from a colleague from the Middle East. Before the new drugs, treating myeloma was like waiting for a taxi and none would come. Then all of a sudden 5 come at once. So I think that's exciting that we have all these options available for patients, but it can be very confusing, and I'll get into why a little bit later on of where do you put all these drugs together? And I know you heard a little bit about that from Dr. Gertz. So this is sort of the history of where we all come from. Now, over on the left, and I adapted this from Ken Anderson from 10 years ago, and the slide's gotten a lot bigger because I keep adding drugs and it's really getting crowded on the right-hand side. So I'm gonna have to sort of push everything over. We started in the 50s with melphalan, and we still have melphalan. It was used at first orally with a steroid called prednisone. It worked okay, not great. And Dr. Kyle's been mentioned earlier, has a really cool article on sort of the history of treatment for myeloma, which included orange peel and some other interesting things which didn't work. And then McElwain in the early 80s pioneered the use of high-dose melphalan. He didn't give a rescue, so these patients were like neutropenic forever as he dose escalated it. And then as mentioned earlier, Bart Barloghi had a lot to do with the field. He pioneered the use of high-dose dexamethasone, which I know everybody loves getting. But the V here stands for vincristine and erythromycin, which we don't use that much anymore. And then he was the one who really sort of pushed high-dose melphalan with a rescue, because melphalan kills good cells and bad cells. It's fairly non-specific. Oh, by the way, BCMA is not specific for myeloma cells. It's also on normal plasma cells, just to correct Dr. Gertz. And as well, CD38 is not only expressed on malignant plasma cells, it's on natural killer cells and a variety of other things. It's very immunomodulatory. We can talk about that later. Anyways, the whole idea of stem cell support came about in the 80s. So this has been around forever. Would I love that we stop doing this? Sure, I'd love to have less toxic things that we can do. So that's our goal for the future. And then, as you know, the IMiDs came out, thalidomide being the first. Horrible reputation for birth defects because it was used for morning sickness. And it was crazy. And there was a woman at the FDA who blocked thalidomide for being used in the US. It was used in Europe and Canada. I forgot her name. Somebody made. Thank you, Frances Kelsey. And Wyeth, who had thalidomide, was pillorying her because why is she not releasing our wonderful drug? And she should have gotten a large medal for that. I think she did. She was given awards because what she did was prevent a huge number of birth defects in the US. However, it was repurposed later for leprosy and then later on for multiple myeloma. That's a whole nother story, which I won't get into now. Then there was lenalidomide, derivative, pomalidomide. And now we have, because for marketing purposes and for patent reasons, derivatives of these drugs are now called the CELMoDs. And iberdomide and mezigdomide, which I haven't yet figured out how to pronounce, are going to be hopefully available in the near future. We have the proteasome inhibitors, as was discussed earlier, and then all monoclonals. Elotuzumab, which is against CS1, also known as SLAM-F5. It's okay, not great, but DARA is much better, as is ESA, both against CD38. But in addition to actually hitting the myeloma cells and killing them, they also do a lot in terms of modulating your immune system. And in fact, some of the CAR T cell programs incorporate potentially daratumumab, help deplete natural killer cells. That's another discussion. Some of you may have seen belantamab mafodotin or belamaf. That's an anti-CD38 antibody drug conjugate, very cool. And then sub-Q daratumumab, and then we'll have the bispecific antibodies against BCMA and then GPRC5D, which are teclistamab will probably be approved by the end of the year or early next year, and talquetamab sometime beyond that. And then we have selinexor, panabinostat, which isn't used too often. And then the BCMA-directed cellular therapies, ide-cel and cilta-cel. So we got all these things that potentially will replace transplant, which is fine with me. Just to give you an idea of just how hard it is to take care of cancer patients in general, is that when you go into remission, the level of remission is about 1 billion cells. 1 billion cancer cells is about the size of a sugar cube. So I can take a sugar cube's worth of cancer cells, stick them in me, and I won't find them until I have 10 billion cancer cells. In other words, they have to grow. So it's sort of like the tip of the iceberg phenomena, so that once you go below that tip, you now are treating, but you don't know exactly what's going on because you have to wait and see. So a lot of what we do is based on, well, what do we have for prognostic signals that we get from the myeloma at the get-go? So cytogenetics, stage of disease, a variety of things go into helping us understand what is the prognosis for a particular patient and what's the likelihood the cancer will come back sooner rather than later. That's another discussion, but that's why you get all these tests done when you are first diagnosed, to help us understand what the prognosis may be. So what's the best therapy? That's another discussion, which we'll talk about a little bit later. I think Dr. Hillengass will. And so what's the role of melphalan and high-dose melphalan and stem cell transplant? It's really not a transplant, it's a rescue. You're getting your own cells back. A transplant's when you get something from somebody else. And then what's a transplant eligible patient? In France, it used to be up until 65. You hit 65, no transplant for you. But now they're expanding it. In the US, it's really not age, it's fitness. And then everything gets different, fit and frail. So a lot of it's organ function, heart, lungs, musculoskeletal, how much can you walk around? But patients who are in organ failure with kidney failure, who are on dialysis, they can get a stem cell transplant with high-dose melphalan. Bart Paralogi pioneered that. Also, a lot of it's attitudes. Some people don't want to do it. Some people do. And so, I mean, there's all these factors that go into whether or not we should do a transplant. Okay, I'm just going to do some quick definitions. I'm happy to share this. I'll trim it down if you want to put it into a PDF if anyone wants it. How much more time do I have? 10 minutes? I know we start a little late. Just let me, okay, so this is important when you are interpreting data. I know I don't want to get too scientific, but I think it's important because we make decisions on what to do, and the FDA makes decisions on what to do in approving or not approving a drug based on progression-free survival and overall survival. Those are both very important elements when we look at whether or not you're going to approve a drug or not. In fact, you may know melflufen, which was on the market for a very short period of time, seemed to look very promising, but unfortunately, it had a nice progression-free survival, but it had an inferior overall survival. People actually did worse. So, and they're in the middle of trying to salvage that drug. Same thing with venetoclax, inferior overall survival, better progression-free. So very important. Progression-free is the length of time during which the treatment of disease such as cancer, the patient lives with the disease but doesn't get worse, or they've gone into remission and then it comes back. That's progression-free survival. Overall survival is obvious. You are treated for your cancer, and if you're alive, you have met an endpoint, but if you die, you've met another endpoint. So that's overall survival. We want to have, obviously, an improvement in overall survival. And then the median overall survival or median progression-free survival is the time for which, if you take 100 patients requiring therapy, 50 will either have died or 50 will have progressed, and that's the halfway point. So that's very important as well, because you may see all these things in papers or your doctor may describe this to you. So it's good to have a rudimentary understanding. I don't understand all of it either. I have to talk to our statisticians half the time. So a Kaplan-Meier analysis, I'll go through this very quickly, is to estimate progression or survival. And then you follow all patients, but everybody doesn't get treated on the same day. They're all treated on different days. And then some people may say, I don't want to do this anymore. So they go off study, or they move out of town and nobody can find them. So there are all these things that happen while you're trying to do an analysis. These are all the things that make cancer treatment complicated when you're doing a study, because you got to make sure that you're accounting for all of them, and that also they don't have a toxicity that you're not expecting, and that has happened with several drugs. And so this is I got this from, it's a Vanderbilt thing from Wikipub. And so these are people who've all gotten treatment, the representation. This is just them all lined up, and this is time. And so different things happen to them. Some of them may die, some of them may go off study, some of them progress, and they're all starting at different time points. So what a Kaplan-Meier curve does, it lines everybody up as if they're all starting at the same time. So it's very important. Now, if you've heard this before, I'm sorry, I'll go through it quick. So this is a very simplified Kaplan-Meier curve, just showing percent of people surviving, but what happens is things may happen. They are censored. They leave towns, so you can't follow them anymore. So the curve drops. And then some may meet an endpoint. They've progressed or they've died. And so the curve keeps dropping. So this gives you an idea of how something is working relative to something else. And I'll show you that in a little bit. So this is from a fellow named David Robinson. He presented in Blood few years ago. And what it shows is, actually, this is an abstract. He presented in a different journal. And what it shows is how we've gotten better over time in terms of patient survival. You can see here back in the 70s to 1980s, the median survival here was about, it was pretty bad. It was about 3+ years. So that was back in the day when we really only had oral melphalan. And then as you see over time, we got better so that the median survival keeps rising. So here, the 5-year median survival for patients who were treated, the median survival for patients treated from 2001 to 2010 is about 5 years. but I'll tell you how that's even gotten better. And this is another one that was an abstract, which they published in another economics journal, I think. And this just shows how things have improved. The blue line here is for people less than 65, and then from 2006 to 2010. And this is for less than 65 from 2011 to 2012. And you can see on the Kaplan-Meier curve, things have gotten better. But what's really cool is for the over 65 crowd from 2006 to 10 here has now improved to up here. And you can see it stops here because you have to have patients live long enough for you to be able to follow the curve. So that's another issue. But this is exciting. We've gotten better at what we do. And then lastly, here's auto transplant. It's very simplified. There's our patient in green. This patient has their stem cells collected. Many of you who've had a stem cell transplant know what it's about. We used to do bone marrow harvests, which are pretty crude. Now we do peripheral blood, and even then it'll change because maybe it'll always just be CAR T. Cells are put in the freezer and then very cold. And then patient receives high dose therapy. And people have tried to improve upon melphalan, and really it's still melphalan. So that wipes out the hematopoietic system, cells are infused back in, and then patient is rescued. And for those of you who've had this, you know it's not a lot of fun. So I'm going to start to wrap up. This is the determination trial. Paul Richardson led this. It was just published a few months ago. And this was RVD, which at the time was the gold standard. Everybody got RVD. And they not only did it in the US, they did it in France. And we can talk about it later, the difference between the French trial and the American trial, because there are differences on the maintenance arm. And the patients who got RVD only got it for 2 or 3 cycles, had their stem cells collected, and then got RVD for up to 8 cycles. And then the transplant arm got RVD induction 2 to 3, stem cell collection, high dose melphalan. Then the back end they consolidated, and this is very popular in Europe. In the US, you've just had high dose melphalan, it's day 60. Oh, we're going to give you more RVD again, more patients. Are you kidding me? So that's why we don't do that much. And that's another study where we showed that it probably doesn't matter if you've gotten an RVD induction. And then they all got Len maintenance. And the primary endpoint was progression-free survival. And then there are other safety endpoints and overall survival. And this is that Kaplan-Meier curve. For the patients who got a transplant, they had a superior progression-free survival. In other words, it benefited them in terms of when the disease came back, it progressed, or they were in remission and they had relapse. And the blue line are the patients who got RVD only. And so the median progression-free survival, remember, that's why I gave you all that stuff at the beginning, is 46 months for RVD alone, and it's 67 months for those who got a stem cell transplant. You say, well, why doesn't everybody get a stem cell transplant? Well, the overall survival is not that different. Why? Because we got great salvage options for patients after progression from if they have a stem cell transplant. So right now, there's no difference, and we don't expect there will be over time. So I'm going to end here with a few other things. People have tried to improve on things after transplant. This is one using elotuzumab as part of consolidation maintenance. This is a German study. And you can see here, they had all these different permutations. Len-dex alone, Len-dex plus elo, Len-dex alone, Len-dex plus elo. And they had different approaches. You could either get 2 transplants versus 1. But anyways, the bottom line, no difference when you added elotuzumab. Now, the French study added, this is VTD, which is bortezomib, thalidomide, dex, transplant, and then with or without DARA, and then DARA versus observation. And this shows that DARA as a single agent compared to nothing benefits people with, who received the daratumumab as opposed to nothing. As you know, now the gold standard is, or at least the FDA-approved gold standard is lenalidomide. We can talk about that if you wish. But this is where it gets really confusing. It turns out that the patients who got VTD, thalidomide, bortezomib, and dex, and then no maintenance, they are here in terms of their progression-free survival, inferior. Here, if you look at it though, the patients who got VTD DARA and no for just alone, they did very well. But those who got VTD DARA and then got DARA on the back end for maintenance, they're about the same. And here are the ones who got DARA, VTD, and then observation, also about the same. So daratumumab, as part of induction, seems to have a halo effect that goes well beyond the initial, whoops. Was that me, or are you trying to tell me to go to the next slide? No. So it's an interesting phenomena. So DARA, in addition to killing plasma cells, modulates the immune system. We're just beginning to understand how that works. I can talk about that a little bit later on. So I'm going to end this part of my talk with what the Princess Bride teaches us about outcomes in multiple myeloma. And the sad part is, when I say this to students, they all go, "What's the Princess Bride?" And I'm like, oh my God. So kids, I guess it's like when you talk about the Rolling Stones and everybody looks at you, oh, those are a bunch of old men. So I always do recommend, for those of you who have not seen The Princess Bride, to go see it, because where Vizzini and his, well, as you know, he kept saying inconceivable when something he thought could never happen happens. So his last word was close to inconceivable when he was having with the Dread Pirate Roberts, when he's having the game as to who's going to drink the poison. And so I know Kane poison. So Inigo Montoya is played by Mandy Patinkin, and Vizzini's played by Wally Shawn. So he goes, "It's inconceivable," says Vizzini. And having heard this claim 3 times only to be confronted by alternate realities, Inigo Montoya says, "I don't think you know what that word means." So how, you may ask, does this relate to multiple myeloma? 20 years ago, it was inconceivable that the median overall survival for myeloma patient would now be beyond 10 years. In the 1980s, it was 3 years. Now we're in excess of 10 years, with or without transplant. And to consider alkylator-free regimens for fit or failed patients has become all but routine to use induction regimens that don't use alkylators. Inconceivable. And that post-relapse outcomes could nearly be as long as the initial responses, if not longer in some cases. And the results of phase 3 trials could be confounded by post-transplant therapies. Great problem for the patients. Hard problem for the investigators, because it makes it hard when patients are getting great salvage therapies to say, well, we're going to use overall survival as an endpoint, because now we're able to treat patients quite well. In fact, sometimes even better than the induction regimens they received. Some of the older studies, we used to use a doublet, Lendex. That's like crazy. And so if you get a triplet, so you get Dara Lendex or Dara Pomdex, you may even have a longer response than the original Lendex. So it makes it very difficult to figure out what's going on, even in the context of B-cell maturation, antigen-directed therapy. So I'll stop there. I can talk about CAR T cells. I have some cute slides on that a little bit later. Thank you.